Yes, sir.
So, good evening, everybody. Today we are coming up again with monthly RESPINAR, which is organized by IAP and RC. IAP, this RESPINAR is becoming famous day by day, and we have received continuously calls from people. The reason is that we select very carefully speakers and our moderators for this program. So till now, we have always, selected our speakers and moderators so carefully that all still waters have, joined this program as their lead speakers. So today, continuing this legacy, we have two great personalities. I can say if you go through the literature and Google ABPA, you will get Ritesh Agarwal immediately. And we have equally important moderator, Dr. Pankaj. He is again Professor Pediatric Pulmonology, PGI Chandigarh. Before we formally start the program, I would like to, invite our chairperson at IPNRC, Rawat sir, to have some opening comments. Thank you so much.
Thank you, Javed sir, and good evening to all the delegates who have joined today evening on this very important meeting today, where we have our guest in form of Dr. Ritesh Agarwal. His name is synonymous with research on ABPA, and as Dr. Iqbal has informed that he has made some landmark contribution in ABPA research in the world, and the recently 2024 ISHAM guidelines have got a stamp where they have updated the guidelines on diagnosing and management of ADP. So that is a landmark document, and I think it is followed across the world. So we are very fortunate to have Dr. Rita Agarwal on this platform, where he'll be speaking on what are the recent updates ISHAM guidelines of 2024, and I'll invite all the delegates who are on board to ask questions to clear all your doubt regarding ABP, because he is the internationally known authority, and definitely the session will be very enlightening. I'll also welcome Dr. Pankaj Vaidya, who is a senior professor at PGI Chandigarh. And again, his contribution to IPNRC in academics field is great, and he has been a very helpful figure for all academic environments and programs of IPNRC. Thank you, sir. So I'll request Dr. Javed to take over and start up the proceeding, please. Thank you.
Sir, thank you so much, sir, for your opening remarks. Without wasting further time, I request Professor Pankaj to start proceedings and over to Professor Pankaj.
Thank you, sir. Thank you. Welcome everyone to today's session, and I'm very excited. At the outset, I would like to thank the Indian Academy of Pediatrics National Respiratory Chapter, office bearers, and to the entire team, especially Dr. Javed Iqbal, for bestowing this honor upon me of introducing a star of PGIMR Chandigarh, and also of the entire medical fraternity as such. Uh, and it is a proud privilege for those who don't know him. It is high time that they should know. The reason being very simple is that when we asked for his CV, he has given just one PowerPoint slide, but it speaks tons about his capabilities and the heights he has achieved. Wherein his number of publications is 721. His citations, which he mentioned, were something around 28,000, but when I just checked today, it was 29,037. His H index he mentioned as 87, but I checked it, it is 88. So that is according to the Google Scholar, and I feel very proud to say that he's one among the highest with citations and also H index in the entire PGI and AIMS. And just to a brief introduction, because if I start reading his CV, I think it would take a full day. But just to brief, he is a product of the Stanley Medical College. He did his MD in internal medicine from PGI Chandigarh, and his DM in pulmonology from PGI Chandigarh. And there is no pulmonology journal in which he has not published, and no grant or award that he has not received. And the most notable one is the Shanti Swarup Bhatnagar Award for Science and Technology, which all of us know is a very prestigious and coveted award. And he is the few who has achieved this milestone. So I would uh, like to thank IIP NRC for choosing this topic for today, because as such we don't have any direct guidelines for pediatric population for the ABPA, but Professor uh, Ritesh Agrawal has done a great job by including pediatric studies in the guidelines that he has made in 2024. And we have invited him because everyone knows that he is the one who has framed the ISHAM 2024 guidelines. And not only that, he is one of the founder members of Indian Society for Human and Animal Mycology, and it is like the standard authority on fungal disorders all over the world. And this society guideline today, we are going to request Dr. Ritesh Agrawal to simplify for us how we can use them for optimizing the diagnosis and treatment of ABPA in children. So, with that, on behalf of the entire audience or our delegates and IIP NRC, I invite Professor Ritesh Agrawal to deliberate his uh, lecture and uh, make us aware about the updates in this field. Welcome, sir. Over to you.
Thank you, Pankaj, Javed, and Dr. Rawat for having me here. It's indeed a pleasure and an honor to be a speaker at this IAP NRC RESPINAR. In the next half an hour or so, what I'll do is I'll I hope the slides are showing up.
Yes,
Yes,
sir.
sir. Please make it full screen, sir.
Are they full screen?
No, sir.
There's some issue with the. Are they full screen now?
No, sir, they are not full screen.
असेच गेले एम्पेरिकली कुठे
Sorry?
कल्चरमध्ये कुठेच काहीच नाही आलं तरी पण लहान मुलाला असं इन्फेक्शन लागतात त्याच्यासाठी आम्ही एम्पेरिकली सांगते ते गाईडलाईन्स असते
So while you are sharing, you please share the entire screen if that solves the problem.
That is what I'm trying to do, Pankaj.
Yes, sir.
So I am trying to share the screen.
Yes, sir.
The entire screen, only in the window, the slides are.
Yes, sir.
Coming.
Now you can make it in the PPT mode, the full mode. That's all.
Is
Yes,
it
sir.
full
Yes,
screen
sir.
now?
Yes.
Yes, sir. Yes, sir.
Okay.
Now is it okay?
Okay.
It's okay.
Thank you for all the technical support, and sorry for the glitch. And so what I'll do in the next half an hour or so is to discuss the newly updated ISHAM guidelines, which are the International Society for Human and Animal Mycology guidelines. and see how they can be optimized to improve the diagnosis and treatment of ABPA in children. So this is the ISHAM guideline. This is a collaborative effort from 45 international experts across 13 countries, and I have highlighted the pediatricians in the working group. So these guidelines are intentionally comprehensive. They include both adults and children. They encompass patients not just with asthma, but also cystic fibrosis, bronchiectasis, and chronic obstructive pulmonary disease. And these guidelines are meant both for clinical practice and research with the specific recommendations for each context. So why do we care so much about ABPA? The most important reason is that the disorder responds remarkably to treatment with the glucocorticoids or antifungal triazoles. In fact, we see dramatic improvements in our patient, which can be transformative. Second, and perhaps the more important reason, is that early detection and treatment can prevent the progression of bronchiectasis. In fact, ABPA is considered as a treatable trait in patients with bronchiectasis. So one of the most significant updates in the guidelines is regarding terminologies and definitions. Now the guidelines have broadened the definition of ABPA to include immunological reactions against any Aspergillus species, not just Aspergillus fumigatus. And the definition of ABPM now includes immunological reactions against fungi other than Aspergillus species. Now, this change reflects real-world clinical practice where the identification of fungus is not always important for treatment of the particular patient, but is more important for epidemiology and research purposes. This slide shows the prevalence of ABPA in asthmatic adults visiting tertiary care. So this was a more recent meta-analysis where we looked at 47 studies which encompassed about 10,000 asthma patients. And you can see that the prevalence is about 11% in tertiary care. Now this slide shows the prevalence of ABPA in asthma, another systematic review meta-analysis. There are two important points to be understood from this slide. First is that the disorder is most common in India. Here you will see all the reported data on ABPA is from India. In fact, from the United States and the United Kingdom, the asthmatic patients, none of the kids had underlying ABPA. So there's something in India which increases the prevalence of ABPA, be it in adults or in children. And you can see the prevalence is almost similar to that of adults. Almost 1 in 10 asthmatic children also develop ABPA. Another issue in pediatric ABPA is the occurrence of ABPA in cystic fibrosis. This is another systematic review, a bit old. We did it about a decade ago, 45 studies, 35,000 cystic fibrosis patients. And again, the prevalence is fairly high. So you see a high prevalence of ABPA in pediatric asthma and CF patients. So the guidelines recommend screening for ABPA based on these compelling epidemiological evidence, and the evidence is that almost 1 in 10 asthmatic patient in tertiary care can have ABPA. Contrary to the historical belief, while most patients with ABPA have moderate to severe asthma, many will have mild asthma. So ABPA occurs across the asthma spectrum, not just moderate to severe asthma. And third, and perhaps the most important point, which I already mentioned, that there is a high risk of progression to bronchiectasis if ABPA is undetected. So the recommendations for screening include to evaluate for Aspergillus sensitization in all adult asthmatics diagnosed in tertiary care. And the screening modality is specific IgE. The most commonly used platform is the ImmunoCAP IgE platform in preference to a skin test. Whereas in children, the guidelines recommend evaluating only children in those with difficult to treat asthma. Now, the evidence for this statement was not very robust. It was more of an expert opinion, and the pediatricians in the working group felt that it will be too much that if we evaluate all children. But 4 months, at least I personally believe that in tertiary care, at least children were diagnosed as asthma, especially those who have even mild asthma requiring constant or regular dose of inhaled corticosteroid should be evaluated for ABPA, because the test is one, simple, just a blood test, and it's widely available and it's not very expensive. So I think the modality for screening is also very safe and sensitive. Now let's briefly look at the pathogenesis of ABPA. Understanding the how or why helps us explain the what of treatment and diagnosis. So ABPA pathogenesis involves 4 interdependent processes. Step 1 is fungal persistence. Aspergillus fumigatus conidia, as we all know, are ubiquitous in the environment. In susceptible individuals, they persist in the airways because they are not cleared, which is due to facilitation by abnormal mucociliary barrier, epithelial airway dysfunction, and dysregulated innate immunity. So step 2 is immune activation. The persisting fungi activate innate immune process by activating the pattern recognition receptors and the adaptive immune process by dendritic cell lymphocyte interaction. The third step is Th2 polarization. This is a key step in ABP pathogenesis, with abnormal type 2 immune responses, which are orchestrated by type 2 innate lymphoid cells and Th2 lymphocytes, which result in the secretion of interleukin 4, interleukin 5, and interleukin 13, with the resultant IgE class switching, eosinophilia, and mucus hypersecretion. And the final step in pathogenesis is eosinophil-mediated destruction. Activated eosinophils cause the release of toxic granules and charcut-laden crystals, which are nothing but aggregated protein of galactin-10, plus the activated eosinophil form eosinophil extracellular traps. All of this over time cause mucus plugging and bronchiectasis. Most importantly, genetic susceptibility underlies all these processes, with polymorphisms affecting epithelial cell integrity, fungal recognition, antigen presentation, and cytokine signaling. So let's look at the diagnostic toolkit for ABPA. So this 2021 publication from our group looked at the diagnostic performance of all the routine investigations that are used for diagnosing ABPA. And we found that there are 4 tests which are important for ABPA diagnosis. These include specific IgE against Aspergillus fumigatus, specific IgG, serum total IgE, and chest imaging in the form of chest CT. First, coming to specific IgE. Specific IgE against Aspergillus fumigatus is the most sensitive investigation in the diagnosis of ABPA, and at the cutoff value of 0.35 kilounit of antibodies per liter, has a sensitivity approaching 100%, making it the preferred test for screening asthmatic patients for ABPA. However, as you can see here, that the specificity is about 65%. So this brand new research from our group asked the question whether the ImmunoCAP AFIG threshold can be optimized for ABPA screening. So in this study involving 900 plus patients in both derivation and validation cohorts, we looked at the sensitivity of the threshold of 0.35 and looked at the sensitivity and specificity of various thresholds. So we included 0.5, 0.7, 1, 3.5, etc. So what we found was that at 0.35 kilounit of antibodies per liter, the sensitivity was 100%, while the specificity was 67%. On increasing the threshold to 0.7 kilounit of antibodies per liter, the sensitivity decreased, but not statistically significant and not clinically meaningful, whereas the specificity improved from 67 to 73%, which was both statistically significant and clinically meaningful. So if you screen 1,000 patients, if you use the 0.7 cutoff, it will reduce unnecessary testing in at least 58 of these patients. So what we suggest is that you screen the asthmatic patients for ABPA using specific IgE, and only if the cutoff is 0.7 or if the value is 0.7 and above, you work the patient further for ABPA. Between 0.35 and 0.7, you can observe the patient and perform further investigation only if the asthma control gets worsened. So this is another recent research from our group. So consequent to the change in ABPA definition, we asked the question whether a broader testing can improve the ABPA detection in asthmatic patients. So we used an antigen called as MX4, which has antigens against 4 Aspergillus species, namely Fumigatus, Flavus, Niger, and Terrius. So again, 328 subjects in both derivation and validation cohort. Contrary to our hypothesis, we found that specific IG remained the most sensitive screening tool, and MX4 IG offered no diagnostic advantage. So at present, the most important test for screening asthmatic patients for ABPA is Aspergillus fumigatus specific IgE. Serum total Ig is a useful test in diagnosing ABPA as it indicates systemic immune activation. So two cutoffs have been widely used in literature: the 500 international units per milliliter and 1000 international units per milliliter. If you know about the 2013 ISHAM criteria, in that we had used the 1000 international units per milliliter threshold. However, the group this time felt that the threshold should be lowered because we wanted to improve the sensitivity in the first step. As once I discuss the diagnostic criteria, at this point will become clear why we want to improve the sensitivity of the earlier investigations and the specificity of the later investigations. So the currently used cutoff is 500 international units per milliliter. Serum total Ig is also the preferred biomarker for monitoring treatment response in patients with ABPA because it reliably decreases following treatment and reliably increases during an exacerbation. Serum precipitins or IgG against Aspergillus fumigatus is another useful test, and in fact was one of the earliest immunological tests used for diagnosing ABPA. Unfortunately, if you're using precipitin method, which is a double diffusion method, it has a very low sensitivity of only 27%, whereas if you're using the enzyme immunoassay platform, the sensitivity catapults to about 89%. In fact, in a systematic review, we showed that for every 6 tests that are performed with immunoassay platform compared to the immunoprecipitation platform, one additional patient of ABPA can be detected. So specific IgG using EIA, the enzyme immunoassay, is preferred to serum precipitants. Peripheral blood count, peripheral blood eosinophil count is another important test in ABPA diagnosis. The previously used threshold of 1000 cells per microliter has a sensitivity of only 40%, whereas the 500 cells per microliter threshold has a sensitivity of about 75%, and the ISHAM guidelines and the working group has accepted this cutoff as the cutoff to be used for the diagnostic criteria. Next, coming to sputum cultures. Sputum cultures have a limited role in diagnosing ABPA. Unlike invasive pulmonary aspergillosis or chronic pulmonary aspergillosis, allergic bronchopulmonary aspergillosis is an allergic disorder. So while Aspergillus fumigatus is important for pathogenesis, the yield of a routine sputum culture is very low. That's why the sensitivity is low. And the specificity is also low because Aspergillus fumigatus, as many of you will understand, is a ubiquitous fungi. So you can have a positive culture even in normal individuals, and especially in asthmatic patients without ABPA. So it is both poorly sensitive and poorly specific, and is not recommended as a routine test in diagnosing ABPA. It is, however, an important test in diagnosing ABPM, which is allergic bronchopulmonary mycosis, here because you don't know which fungi is implicated in the pathogenesis, and sputum cultures helps you guide in detection of that fungi. Sputum cultures are also useful in assessing antifungal resistance in patients with refractory disease or those on prolonged antifungal therapy. A word about recombinant Aspergillus fumigatus antigens. currently the antigens which are used for diagnosing ABPA are derived from crude Aspergillus fumigatus extracts, and they are limited by their purity, and they frequently cross-react with other fungal antigens. In fact, our group and the Japanese group have shown the utility of recombinant Aspergillus fumigatus antigens, specifically F1, F2, and F4 for diagnosing ABPA. Unfortunately, their usefulness has now become paradoxically limited because of the change in definition. For instance, the definition now includes all Aspergillus species, and if you use fumigatus specific recombinant antigens, it will miss the non-fumigatus ABPA. So the current utility of these recombinant antigens are for accurately diagnosing ABPM and ABPM mimics like tropical pulmonary eosinophilia, eosinophilic granulomatosis with polyangiitis, and other related disorders. And it can be used as other criteria for ABPA, which we'll come to shortly. And we and others have shown that there is no utility of measuring IgG against recombinant antigens. So what we actually need now is a pan-Aspergillus specific antigens which can detect all the Aspergillus species and not just Aspergillus fumigatus. Imaging is useful, and imaging is characteristic for diagnosing ABPA. Chest radiograph shows the transient opacities, which is due to mucus plugging, the finger in glove, the toothpaste, and the fleeting opacities. Thin section chest CT is the imaging modality of choice in diagnosing ABPA, the most common abnormality being bronchiectasis. However, the pathognomonic finding is high attenuation mucus, which is defined as mucus that is visually denser or mucus that is more radiodense than paraspinal skeletal muscle. So if you find HAM in a patient with bronchiectasis, it clearly indicates that the underlying cause of bronchiectasis is allergic bronchopulmonary aspergillosis. A lateral flow assay is also now available, the LD Bio-Aspergillus immunochromatographic test, and we, in a recent study, showed the sensitivity and specificity of this point of care test. The diagnostic performance was reasonable, however, it was still inferior compared to the other enzyme immunoassay platforms, specifically the ImmunoCAP platform. However, these lateral flow assays have certain advantages. One, they are point of care. Second, they don't need a laboratory infrastructure. And third, the results are available within 30 minutes. So if you're trying to use this test in a field setting, then it is of some value. I think in another year or so, you are also likely to have a point of care lateral flow assay for Aspergillus fumigatus specific IG. So you can, in fact, exclude a diagnosis of ABP in your clinic within half an hour. Just a word about serum galactomannan. Serum galactomannan, as many of you will know, is one of the useful investigations for diagnosing invasive pulmonary aspergillosis, but its diagnostic performance is dismal in patients with ABPA, so it should not be used for diagnosing ABPA. The second important point why I brought serum galactomannan is, in my practice, I've seen in many clinical situations that people use a serum galactomannan positivity as being indicative of invasive pulmonary aspergillosis in patients with ABPA. Please, it is not correct, because you can have a positive galactomannan in as many as 1/4 of the ABPA patients. So the diagnosis of IPA cannot be based solely on a positive serum galactomannan in ABPA patients. And finally, it is important to remember that the patients who have ABPA and bronchiectasis can have another underlying cause for bronchiectasis. So in all pediatric ABPA B patients, that is pediatric ABP associated bronchiectasis patients, you need to exclude other causes of bronchiectasis, other competing causes, I mean. So all patients should be investigated with sputum for acid-fast bacilli and mycobacterial cultures. I understand in children, getting a sputum sample may not be feasible in all, but I think gastric aspirate and whatever modality you use for excluding non-tuberculous mycobacteria can be utilized for excluding this condition. All patients should have an immunoglobulin levels, specifically IgG, IgM, and IgA, to rule out immunodeficiency disorders. A sweat chloride is mandatory to rule out cystic fibrosis. And I, for one, always believe that in pediatric ABPA, one should do whole exome sequencing to rule out underlying cystic fibrosis, ciliopathy, and other immunodeficiency disorders. So let's look at the diagnostic criteria for ABPA. This slide shows the chronology of the ABPA diagnosis over time, with the first description by Hinson and colleagues way back in 1952 to the most recent ISHAM consensus diagnostic criteria. So the revised or the 2024 ISHAM diagnostic criteria has 4 tiers to simplify the diagnosis and make it applicable for clinical practice. So the first step is that ABPA should be suspected in patients who have underlying predisposing conditions which include asthma, cystic fibrosis, and bronchiectasis. Chronic obstructive lung disease is obviously not very much applicable in the pediatric population. If the patients have no predisposing conditions, then ABPA could be suspected in patients with compatible clinical radiological presentation. So if the patients have neither a predisposing condition nor a compatible clinical radiological presentation, it is prudent not to waste investigation like specific IG in patients with non-specific cough, etc. Because a positivity will lead you nowhere. The specificity, like I said, is only about 65 to 73%. So you're likely to encounter more noise than signal. So once you have suspected that the patient is likely to have ABPA, the first step is to document fungal sensitization, and in ABPA it's to document Aspergillus sensitization by doing specific IgE against Aspergillus fumigatus. And if the value is more than 0.35 kiloliter of antibodies per liter, then you diagnose the patient as having Aspergillus sensitization. The next step is to document immunological activity, and that is done using serum total Ig and a value which is at least 500 international units per milliliter, suggests that the patient has systemic immune activation rather than mere sensitization. And if the patients meet both the essential criteria, then you confirm ABPA with 2 or more of the following: IgG against Aspergillus fumigatus, a blood eosinophil count, or a chest CT that is consistent with ABPA. Now you'll be able to appreciate that why we are insisting on having more sensitive tests upfront and more specific tests later, because you really don't want to miss any patient with ABPA. So you are ready to accept some noise, but in the later stages, you want more signal rather than noise. The ABPM structure mirrors the ABPA diagnostic criteria. Here, the specific IgE against Aspergillus is replaced by fungus-specific IgE and IgG. And here, the guidelines acknowledge the importance of sputum cultures, because we understand that commercial assays are not available for all the causative fungi. So this is in a nutshell the 2024 guideline, the diagnostic criteria for ABPA and ABPM. So now the new guidelines have also defined imaging classification, which is now more structured. So ABPA is classified into 5 radiological categories, namely serologic ABPA, which is ABPA-S, ABPA-associated bronchiectasis, ABPA-B, ABPA with mucus plugging, ABPA with high attenuation mucus, and ABPA with chronic pleuropulmonary fibrosis, or ABPA-CPF, and we'll see one by one. So here you can see that this patient has serologic ABPA. Patient meets all the immunological diagnostic criteria for ABPA, but has no bronchiectasis on chest CT. This is a patient of ABPA where the bronchiectasis has become established. Now you can see dilated bronchi, signet ring sign, and so on and so forth. This is ABPA with mucus plugging. Here you can see bronchiectasis, which is filled with mucus. So this is a patient who has ABPA, has bronchiectasis, but has active inflammation, which is depicted by mucus plugging. And this is ABPA with HAM, or ABPA with high attenuation mucus. Here you can see mucus that is visually denser than paraspinal skeletal muscle. This is the pathognomonic finding of ABPA. And finally, you have ABPA with chronic pleuropulmonary fibrosis. Here you can see patient has extensive fibrosis, pulmonary hypertension with the pulmonary artery bigger than the corresponding aorta. So this is a patient who has advanced ABPA. So let's see, summarizing the individual investigations, the diagnostic criteria, and the radiological categories, how we can apply this knowledge at the bedside. So, in patients who have predisposing factors or compatible clinical presentation, you first get a specific IgE. If it's more than 0.35, then you get a total IgE. If it is 500, then you get eosinophil count and specific IgG. And then on a chest CT, you classify the disorder as having uh, bronchiectasis and so on and so forth. If the specific Ig is negative and you still suspect that the patient can have an allergic fungal airway disease, then you go ahead with sputum. And in older children, you can do bronchoscopy and a bronchoalveolar lavage to identify the culprit fungus. Then you can ask your lab to prepare the antigen against that culprit fungus, document sensitization, and then the algorithm follows the same structure as ABPA algorithm. So I hope the diagnostic criteria and clinical algorithm is clear, because now we're entering into a more complicated domain, which is clinical categorization of ABPA. The chronic and relapsing nature of this disorder necessitates a framework where we can accurately classify the disease so that it can have treatment implications. So the new guidelines have simplified the clinical classification from 7 stages. Now we have 5 stages, and each category now defines a particular treatment uh, uh, characterization. So now the new classification divides ABPA clinically into 5 categories. First is the acute stage. This includes both newly diagnosed ABPA and ABPA exacerbation. So newly diagnosed ABPA is a patient of ABPA who has not received any treatment in the past, whereas exacerbation is worsening of a previously controlled disease. So ABPA exacerbation is diagnosed in a patient who has sustained clinical worsening or radiological worsening and increase in serum total Ig by at least 50% of the last recorded Ig value during clinical stability. Needless to mention that you need to exclude other causes of worsening, which includes asthma exacerbation and a bronchiectasis flare, because the management of these complicating conditions are entirely different. Now, here the guidelines clearly say a sustained worsening, which excludes transient day-to-day worsening, which is often seen in asthma patients, and the total Ig criteria prevents a premature classification of ABP exacerbation. The next stage is treatment response. Here, the patient has improved after you have initiated a treatment, and this is defined as symptomatic improvement by at least 50% after 8 weeks of treatment, and either major radiological improvement or decline in serum total Ig by at least 20%. So this is how we define treatment response. Now the guidelines have objectively defined the treatment response so as to ensure consistent assessment across centers, which will be very useful for conducting clinical trials. Then remission is a patient who has sustained response and is defined as sustained at least 6 months clinical radiological improvement of glucocorticoids and lack of rise in total Ig by at least 50% from the last recorded Ig value. Here, the 6-month window prevents or ensures that the remission is sustained rather than some temporary improvement. And again, the Ig cutoff criteria prevents premature classification. Another important change in remission is that patients on biological agents or long-term antifungals may also be considered in remission if they meet this criteria. So the guidelines acknowledge that some patients can achieve remission only with the use of long-term treatment. Treatment-dependent ABPA represents the most challenging clinical scenario and is defined as 2 or more consecutive ABPA exacerbations, each occurring within 3 months of stopping treatment, or in a patient who has worsening respiratory symptoms and worse imaging or rise in serum total Ig by 50% within 4 weeks of tapering oral steroids on 2 consecutive occasions. So these are patients who are truly treatment dependent and require long-term management strategies. Finally, you have advanced ABPA, which is defined as extensive bronchiectasis due to ABPA and presence of either cor pulmonale or chronic type 2 respiratory failure. Here, the disease is fairly advanced and patient requires additional palliative management apart from treating ABPA. Please remember that even in advanced ABPA, patients can have immunologically active disease requiring ABPA specific therapy. So now we have looked at the diagnosis, diagnostic investigations, the criteria. Now let's look at the next part, which is the treatment of ABPA. So the pathogenesis of ABPA involves two key steps, which is fungal colonization and skewed or dysregulated type 2 immune responses. And thus the management principles include the use of anti-inflammatory therapy to control the immunological activity, primarily with oral corticosteroids, but increasingly now with the monoclonal antibodies or biologics against specific targets, and the use of antifungal agents to attenuate the fungal burden in the airways, again most commonly with oral triazoles, but in specific situations with inhaled amphotericin B. So let's look at the guideline recommendations. So for a newly diagnosed ABPA, the guidelines recommend either prednisolone or oral itraconazole each for 4 months as the preferred initial therapy. So this is a paradigm change in the treatment protocol because ABPA has always been prednisolone first disorder. So the new guidelines are now categorical that either prednisolone or oral itraconazole can be used as first-line therapy for treating acute ABPA. In fact, the guidelines recommend against a combination of itraconazole and glucocorticoids as first-line therapy for acute ABPA. However, if you're using oral itraconazole, a short course of prednisolone may be used initially if the patient has very uncontrolled asthma. Another crucial clinical pearl here is regarding serologic ABPA, which is ABPA without bronchiectasis. The guidelines are clear that systemic therapy is required only if there is poor asthma control or recurrent exacerbations despite optimal asthma therapy. And finally, asymptomatic ABPA patients do not require treatment with systemic therapy. These patients require close observations with treatment required only if the patient become symptomatic. So why, you would ask, why, how can a patient of ABPA be asymptomatic? This situation occurs in asthma clinics where there's a routine ABPA screening policy, like our clinic, where we often find patients who are asymptomatic and who can just be managed with asthma treatment. The guidelines are also explicit about what should not be used as first-line therapy. So oral voriconazole, posaconazole, and other newer azoles like isavuconazole should not be used as first-line agents for treating acute ABPA. Similarly, high-dose inhaled corticosteroids should not be used as primary therapy for acute ABPA. While inhaled corticosteroids are important for controlling the underlying asthma, they do not achieve sufficient systemic anti-inflammatory therapy to control the ABPA immunological activity. Again, biological agents are not recommended as first-line therapy. Here you will see the LOC. LOC is the level of consensus. This is the expert agreement for guideline statement. So here you will see that biological agents, uniformly the experts recommend against it to be used as first-line therapy. For ABPA exacerbations, the first-line therapy is now similar to how we treat newly diagnosed ABPA. So you give, again, either prednisolone or itraconazole, and in pediatric ABPA, itraconazole is always preferred compared to oral corticosteroid because of other issues like growth retardation and other things. In patients who have recurrent and frequent ABPA exacerbations, a combination of oral prednisolone and itraconazole can be used. Similar to newly diagnosed ABPA, biological agents or nebulized amphotericin B are not recommended for treating ABPA exacerbations. For treatment-dependent ABPA, the guidelines recommend 3 evidence-based options, which include the use of long-term itraconazole, nebulized amphotericin B, or biological agents. Here, alone biological agents are recommended for treating ABPA. For patients who have achieved remissions, the guidelines clearly recommend that patients in remission should be managed for their underlying asthma and bronchiectasis according to the existing guidelines. This statement seems intuitive that patients should be managed for underlying asthma, but in our practice, we saw that many patients who achieve remission, the clinician would stop all the treatment, including inhaled corticosteroids and LABA, and patients would present to us with acute asthma exacerbation. So it is clear that you need to manage these patients for underlying asthma. And for patients who have achieved remission with either antifungal azoles or biological agents, periodic assessments are required to determine the need for ongoing, determine the ongoing need for these therapies. And this slide shows the actionable dosing protocols. So what we used for what is recommended for ABPA treatment in the pediatric population. I'm myself I'm not a pediatrician, so I don't treat many pediatric ABPA patients, but I do get a lot of referrals, and I always refer the dosing protocols before prescribing them treatment, and this is what I use in my practice. So if there's any discrepancy, we can thrash it out in the discussion subsequently. And this is the dose of biologicals which are recommended in children. Now, at least 3 biologicals. In fact, dupilumab is also now recommended in children above 6 years. My experience is limited to the use of omalizumab in children, primarily because the other biologics are not available in the doses which are recommended for children currently. And if I've used the other biologics only in the adolescent age group and not in the true pediatric age group. So these are the specific indications for biological agents. The biological agents are indicated when there is contraindication or intolerance to both oral corticosteroids and antifungal triazoles, or a disease which is refractory to both these agents, or in patients who have uncontrolled asthma despite oral glucocorticoids. So this is where the biological agents are recommended in ABPA. And this is in a nutshell the treatment protocol. Newly diagnosed ABPA, either steroids or itraconazole. I would always prefer itraconazole in children. You follow these patients with the X-ray, spirometry, total IG, and if you classify this as if you classify these patients as having a response, you continue the treatment for at least 4 months. And if they're stable for at least 6 months after stopping treatment, you classify them as having remission. First exacerbation is treated in the same fashion as newly diagnosed ABPA. And in those with frequent exacerbation, you can use combination therapy. And in patients with treatment-dependent ABPA, you can use any of these evidence-based options. A word about how to assess treatment response. So the 3 pillars of monitoring treatment response is first the timing. Don't monitor the patients too early or too late. So it so happens in patients with ABPA that you can have initial worsening. So if you do an X-ray or total IG, say 2 to 4 weeks after initiating treatment, you will find that the X-ray has indeed worsened and the IG has in fact increased. So please don't do it very early and not obviously too late. The assessment is multidimensional using clinical review, total IG and chest radiograph, and therapeutic drug monitoring is mandatory in patients who are receiving itraconazole or posaconazole or voriconazole. Even in routine clinical practice, symptom monitoring should be done using semi-quantitative Likert scale, because this is better than just asking whether you've improved or whether you're not improved. And a more quantitative scale or a quality of life questionnaire can be used for clinical trials. And this is a recently described score known as the Equal ABPA score. This is a tool to measure guideline adherence and treatment appropriateness. This is useful for quality improvement initiatives and research purposes. So how does the future for ABPA look? It looks quite bright and sunny. So we have this Liberty ABPA 8 trial. This is a phase 2 trial of dupilumab in patients with ABPA. It was successful, and dupilumab is moving into phase 3 trial. This is the trial which we conducted along with other centers. This is a regulatory trial conducted by CIPLA, which evaluated the role of inhaled itraconazole. So this is a novel molecule, inhaled itraconazole. Again, the phase 2 was successful, and now we are quickly moving into phase 3. And our group has looked at the role of this novel steroid deflazacort. This is believed to have a lower metabolic side effects when compared to routine prednisolone. So future for ABPA looks quite bright to me. And we'll just wrap it up with a case. A 12-year-old male child, asthma, diagnosed ABPA, referred to our clinic for recurrent asthma and ABPA exacerbations and steroid-dependent ABPA. X-ray showed fleeting opacities. Chest CT showed extensive bronchiectasis. Here you can see specific Ig is elevated, total Ig is elevated, specific IgG or several count, everything is elevated. We did work this patient for other causes. Sweat chloride was normal. Immunoglobulin levels were normal. And here you can see whole exome sequencing showed no pathogenic mutation. So this was a patient of primary ABPA without having any other underlying genetic predisposition. So this patient was being treated with methylprednisolone, itraconazole, inhaled steroids, long-acting beta-2 agonists, theophylline, and montelukast had developed significant steroid-related adverse effects. So when the patient came to our clinic, we changed the corticosteroid first from methylprednisolone to prednisolone. This is important because methylprednisolone and itraconazole have drug interactions. Secondly, we performed therapeutic drug monitoring, which showed undetected itraconazole levels. So we changed the itraconazole from the conventional preparation to a SUBA preparation. SUBA is supra bioavailable preparation. In contrast to itraconazole conventional capsules, which are available at 100 milligram doses, these are available at 65 milligram. So a therapeutic drug monitoring performed after 2 weeks showed a trough itraconazole level of 1.2. So the therapeutic cutoff is 0.5, and this patient had achieved adequate trough levels. Despite this, the patient experienced 2 asthma exacerbations over the next 2 months. Also, the Ig after 2 months had decreased by only about 10%. So the patient then landed in emergency with another asthma exacerbation. So at this point, we increased the prednisolone dose to 30 milligram and added omalizumab. And for this patient, because of the high Ig and weight, the omalizumab requirement was 750 milligrams per month. So we gave it as although we write it as 375 milligrams every 2 weeks, it's given as 450 milligrams once and 300 milligrams once. So 150 milligrams, 3 injections, and then 150 milligrams, 2 injections every 2 weeks. So despite all this, the patient had another moderate asthma exacerbation, which was managed with nebulized bronchodilators. Initially, there was only mild improvement in symptoms, but over the next 4 months, a remarkable thing happened that there was no exacerbations. And in the next 4 months, we could taper his steroids and itraconazole. And after 8 months of omalizumab therapy, the patient was off all the oral medications. So the patient was very happy and said, "Doctor, for the first time in so many years, I'm not taking any oral medications, just those injections and my inhalers." So this is how treatment response is quite transformative for our patients. So in summary, you need to maintain a high index of suspicion for ABPA and asthma, irrespective of the severity of or the level of control. Screen all asthmatic patients in tertiary care with a specific IgE, and the current guidelines recommend either glucocorticoid or itraconazole monotherapy as the preferred treatment for acute ABPA. And I believe that this newly updated ISHAM guidelines will streamline diagnosis and standardize the management of ABPA globally. So this is the ABPA working group in action. The group worked hard, more hours, hundreds of hours of collaborative discussion, evidence synthesis, systematic reviews, and so on. And the guidelines is truly collaborative and global because of the varied expertise and the global representation of the group. So if you are interested, I would really want pediatricians to join the group because there is very little evidence for ABPA in the pediatric population. And if you are interested, please write to me at this email ID. I think with this, I've completed my presentation. Thank you, everyone, for your kind attention. And I'm ready to take questions if there are any.
Thank you, sir. Thank you so much. And very aptly, you have lived up to our expectations. And a teacher who understands the subject well, only he can explain it well to the audience. And thank you, sir, for that elaborate and precise and minute details which you have covered. It's really appreciable. Uh, so the first thing which maybe all pediatricians would want to know is that mm, although there is not much evidence on pediatric population, but whatever little it is and whatever data has been extrapolated from the adults, so how you think these guidelines can be applied, how well these can be applied to the children, because it's a dynamic population. We are dealing from, say, infants to children up to adolescent. And I remember, as you always say, that the organism is the same, disease is the same, but we all know that because this is immune mediated and the immune system of children is always evolving. So, how do you take it and how do you put it?
So I have two very important points to make, because the guidelines have used the adult cutoffs in the diagnostic criteria: 0.35, 27 milligrams for the IgG, 500 international units for total Ig, and so on. So first thing what we require is really whether these cutoffs are applicable in the pediatric population or not. So what we need is a multi-centric study where you really take asthma patients, consecutive asthma patients. So you don't diagnose ABP according to the ISHAM criteria. So you take consecutive asthma patients and you perform all the investigations in these patients, except of course CT, which is not indicated in asthma patients. So if we can do that, only then we can divide a sufficiently large asthma population into a derivation and a validation cohort, and then look at various cutoffs. So we can apply a Bayesian LCA modeling there to derive a initial cutoff, and then we can validate in the second population. So short of that, I don't see any uh, systematic study that can answer this question. It's a very important question, like you said, because the immune system in children is developing. It is not fully developed. So it is possible that the thresholds which are used in the adult population or in adults are very much different from children. However, having said that, in my experience, whatever children I have seen, almost everyone meet the ABPA criteria. So if at all we are either missing a very early form of ABPA, the serological variant, which anyway does not require treatment, or a disease which I really don't understand in children, where you can have lower cutoffs, a very mild bronchiectasis, and it is very important for us to identify this stage, because treatment can be really transformative here, because you can really prevent the bronchiectasis. So it can so happen that you will not have any ABPA in adults at all if you can do that, and I'll be out of business.
Very true, sir. And that was a nice way of putting things. And that was one of the questions from our senior pediatrician, that in cystic fibrosis also, because now the guideline says the same cutoffs. So
Correct.
how far do you think that this is, because we have a lot of patients of CF and they
Yeah.
land up into ABPA frequently.
Correct. That's another point of contention always, because the cystic fibrosis foundation criteria, they have a lower Ig threshold. They believe that the ABP in cystic fibrosis is different, but it is absolutely wrong. ABP in cystic fibrosis behaves the same as ABP in asthma. The behaves in the sense the immunological criteria and presentation is almost similar. The underlying disorder is cystic fibrosis, so the way it progresses is different, but I don't see any change in the diagnostic criteria. So in the previous guideline in 2013, we were a bit hesitant because we had very limited experience. However, with the advent of whole exome sequencing, we have diagnosed a large number of ABPA patients, and in fact, I would challenge pediatricians to the point that whatever ABPA are thinking that it is the classical traditional ABPA, because of asthma, the patient will have underlying cystic fibrosis if you do whole exome sequencing. So it is completely indistinguishable from ABPA complicating asthma. So that is very important point, and that's why you require more studies in the pediatric population. And that's why I request all the pediatricians, especially those who are interested in ABPA, to join the working group. We'll be really thrilled to have you there.
Oh, that's a welcome initiative, sir. Thank you. And you introduced something about the cutoff value from 0.35 to 0.7, which can be taken as a screening thing, like your
Yeah,
latest
so
study is showing in adults. So can it be taken as something should we look forward to, or something for pediatric population more value
I
of?
think some preliminary study would be required in children, but yes, I mean we can safely increase the threshold. Our study clearly shows that we can safely increase the threshold. So the premise was, can we improve specificity without sacrificing sensitivity? So in a large cohort of about 900 patients, we showed that if you increase the cutoff from 0.35 to 0.7, the sensitivity does not fall significantly. From 99.8 it falls to 98.9, hardly anything, but the specificity improves by 7 points. So it really improves the specificity, so the unnecessary downstream testing is reduced. So if you have some preliminary study in children, I think at least we have changed our practice completely in adult clinics at least.
Right, sir. Thank you. Sir, a point about ABPM and ABPA is very. So when we look at the sputum and we try to isolate the fungus, so that's a mandatory step for the ABPM. And maybe in the sputum or bile, if we get that organism, so it's a rather a diagnostic criteria. So, similarly, does blood eosinophil and sputum eosinophil count also help, which would be rather more easier for
Correct.
us to do in children?
Correct. So that was another very important point raised in the ISHAM working group. Can we have sputum eosinophilia also in the diagnostic criteria? Unfortunately, other than the Canadian group and the Japanese group, most of the experts felt that sputum eosinophil count is not standardized, well standardized. So for measuring sputum eosinophil count, you require an inverted microscope, you require a dedicated technician who is doing only sputum eosinophil counts. So across the board, everybody felt that it will be very difficult in clinical practice to get sputum eosinophil count. One important utility of the sputum eosinophil count is, even if you give oral glucocorticoids, the blood eosinophil count can normalize, but the sputum eosinophil count can still remain elevated. So it will help in diagnosis. Only thing is we require a standardization of the diagnostic method.
Okay, so and similarly, whether because in some parts this specific IgE for Aspergillus fumigatus or other fungi would not be available. So should we say that the skin prick test is
Yeah.
outdated now?
No, no, no. Absolutely not. Absolutely not. The skin prick test is not outdated. Specific IG is preferred, but if you don't have specific IG, you can definitely do a skin prick test. So I have not mentioned today, but if you read the guidelines, it is clearly mentioned that if you don't have a specific IG, don't fret. You can definitely do a skin prick test or an intradermal test, whatever is available in your lab.
So then another question which is coming up, and it's very contentious for us, is that radiation exposure. So the guideline mentioned that CT is crucial. The word crucial has been used, and you know that we how sensitive we have been about doing CTs. But rather, there is another study in which you also are a part of MRI in children with ABPA. So, anything if you can give us a guidance, at least in the centers where some non-radiation modalities are.
Yeah, correct. You could do an MRI, and newer MRI protocols are available which can reliably diagnose bronchiectasis, mucus plugging, etc. I'm sure if your center is having MRI, you could do. Having said that, the radiologist in the working group, Mandeep Garg, he was very dogmatic that the amount of radiation which the pediatricians are worried is really not that much now. They have newer protocols by which they can reduce the radiation dose. They are using different protocols, and so he was very dogmatic that uh, the radiation exposure is not what we used to do in the past. It's very much low when compared, and that's why we were not hesitant in using that word crucial. So that was the other point, and plus he was very dogmatic that If you don't do a CT, somebody else would do a CT. And in fact, that's our experience. Most patients come to us with a CT. I mean, we would tell the patients you had no indication for a CT.
Same, sir, same.
Yeah.
So it's difficult to handle. So at least we have that
Yeah, but if you
benefit
have
of
an
looking
MRI,
at
I'm
it.
all right. I'm all right with that. If you have a good MRI radiologist who can give you a diagnosis, it's worth pursuing that.
Yes, and then again, the classification, rather uh, the clinical classification that has the guideline has given, and you have also elaborated in your presentation. It looks to be very comprehensive and probably would be very helpful in children also. But there is a question in the chat box also, in fact, from our president who is very much there in the meeting, that how to differentiate the exacerbations of ABPA versus the exacerbation of asthma versus the exacerbation of bronchiectasis,
Okay.
which may
Yeah,
overlap and coexist in this.
correct. So for the want of time, I did not go into the detail of that. So it's very easy. For instance, ABP exacerbation will have clinical worsening, IG increase by 50%, and radiological worsening. Asthma exacerbations will have only symptomatic worsening, no IG increase, no radiological worsening. Bronchiectasis exacerbation will have fever, purulent sputum, etc. Will have sputum cultures, no IG worsening, no typical ABPA findings like fingering glove or toothpaste opacity. So differentiating between the three exacerbations is not difficult. And in a prospective study, we saw that only about 5% of cases were there where it was a bit difficult because you had bronchiectasis exacerbation and the patient had simultaneous ABP exacerbation also. So that can also happen. Unfortunately, our patients don't read the guidelines, or ABPA does not read the guidelines. So both exacerbations can coexist in an individual patient. So barring the 5% of patients, it is very easy to categorize these exacerbations reliably into these three categories.
Okay,
In
thank you.
fact, in the
Yeah.
phase 3 trial, we are going to use the same definition as for the regulatory trial also.
Okay, sir, thank you. And there was another question which I think you have already answered that, but just for the sake of it, that which one should be preferred in children, azoles versus steroid for initiating the therapy? So,
I would always prefer a triazole. For me, itraconazole is the way to go. Suppose I have ABPA, what will I take? I will take oral itraconazole. It is as effective as prednisolone and is almost devoid of side effects when compared to prednisolone. Hyperglycemia, hypertension, cataracts, hirsutism, weight gain, Cushingoid habitus, so on and so forth. I mean, but having said that, some patients do not tolerate itraconazole well. So they'll develop significant edema, considerable anorexia, nausea. Um, some of them will develop peripheral neuropathy, heart failure, and so on. And you can't use itraconazole in patients with chronic liver disease, or if the patient is on some other drugs where there's an interaction, so on and so forth. So the good thing is that we have both the options. So you can tailor the options depending on your patient. So let's say a patient is very obese, has uncontrolled diabetes. There you have a clear choice of using itraconazole. So I'm sure, despite all the guidelines, uh, clinicians world over will say no. In my experience, prednisolone only works. You are welcome to use whatever. See, the guidelines can only guide you. It cannot replace your clinical judgment. So, but I would prefer always itraconazole.
so in fact, the change which was offered by this latest guideline of yours, wherein we have an option of choosing azole alone, is like a beacon of hope for us because that steroid toxicity was a issue for us to manage.
Absolutely. And world over, everybody was very concerned about this. So this guideline makes a very paradigm shifting treatment recommendation.
So, sir, which you would agree to that although there is no RCT comparing them in children head on, so it would be the most recommended thing to do a RCT straight away and
Yeah, why
find
not?
out.
Why not? You can do an RCT in children and see it works. See, the one problem with our RCT was that we have not used trough monitoring. I mean, therapeutic drug monitoring in our. So we know that itraconazole has a very erratic bioavailability. So Currently, we have all the therapeutic drug monitoring in PGI and other centers. So, nitroconazole RCT with prednisone will be the way to go in children also. It would really give a stamp to our guidelines.
Okay, sir. So, and there is a question about how good or bad is voriconazole, and other than price, what are the issues?
Voriconazole is a good agent. Otherwise, therapeutic efficacy is as good as steroid. There are several problems with voriconazole apart from the cost. First is the photosensitivity. So in children, it will be difficult to ask the children not to play outside. As it is, they are always on the tablets and other things. And I see all parents asking the children to run away from the houses and play out. If you give voriconazole, you have to restrict your children from going outside. So that is one problem. It has significant photosensitivity. Plus, it can cause visual hallucinations. It can cause darkening of skin, which can be permanent in some patients. So the plus hepatotoxicity and other things. In our experience, the toxicity profile is one which prevents us from using voriconazole. The occurrence of side effects is almost similar to prednisolone, although they're different with prednisolone when compared to voriconazole. The side effect frequency is similar as prednisolone. That's why we prefer itraconazole.
Sir, thank you. Sir, and another question is there, which I would also like to contribute, but before that, please opine. Is there any child you have used both steroid and azoles? There's a
Oh
question.
yes, that's what I said. We often use both steroids and azoles. There is no problem about that, but it is not the first line option. So if the patient comes with an acute exacerbation after say 4 years of treatment for the first episode, you can again use prednisolone and itraconazole. But a child where you're given prednisolone, stop within 4 months, comes again. So that is a patient where you would like to give a combination therapy. So in a patient who has recurrent exacerbation, a frequent exacerbation, a combination therapy is recommended. There is no evidence for this, but still the experts felt it is imperative that we give a better treatment option to these patients. Please remember 2 points here. First, the side effect profile would increase because you're using both steroids and itraconazole as a combination. Second, don't combine methylprednisolone and itraconazole. So itraconazole increases the drug levels of methylprednisolone and can cause iatrogenic Cushing syndrome and secondary adrenal insufficiency. If you want to use combination, always use prednisolone and itraconazole. And now you can say your experience also, Pankaj, please.
Yes, so I think you have answered everything. So we also, so there was a time when we used to give both, but like sir told that there is a head-on study and which says that uh, alone itraconazole is not inferior to steroid or a combination. So maybe that is the way forward. And there would be specific situations like he explained in which one would have to give a combination. And there was one more thing which I picked up in the guideline is that for the initial 2 weeks, we may prefer to give both, which will help us
Yeah. So
reduce that.
for instance, if you're using itraconazole alone, and
Yes,
you
sir.
feel that the asthma is fairly uncontrolled, a lot of wheeze, patient is very symptomatic, and so on. There you can give a initial 2 week of steroid to tide over that crisis because itraconazole takes at least 2 weeks to bring about its efficacy. Maximum of efficacy takes 2 weeks. However, with the Suba preparation, it is earlier. It takes only 1 week. So with the
Yes, sir.
Suba preparation, it's still better.
So, sir, the other question is how good or bad is SUBA, and for children, if there is any data or experience from your side?
I can tell about Suba in adults and Suba in pediatric CF. I don't have any personal experience myself, other than a few patients who are mostly adolescents. We refer all the patients to Pankaj and Dr. Matthews for treating ABPA. We don't treat pediatric ABPA unless they specifically ask for some specific advice, mostly bronchoscopies and other things in very challenging patients. Otherwise, in pediatric CF, there is good data that SUBA preparation was far better than the conventional preparation because it achieved therapeutic drug levels in almost 89% of patients. So that way it is a boon to us actually because the other itraconazole preparation have a very erratic bioavailability and SUBA preparations have a very good bioavailability. So in a prospective study, we saw that almost 95% of our patients could achieve drug levels. In only 5%, despite the maximum dose, we could not achieve drug levels, and we have to shift the patient to an alternate treatment strategy. I think SUBA preparation is the way to go, and it's cheaper than conventional preparation. That is the better part of it.
Okay.
Despite being a super bioavailable preparation, that's how India is. Some things are very different and very contradictory in India.
Yes, sir. So maybe this SUBA needs more data and to
Yeah,
kind
I
of
think if
put
you
together.
at least have your clinical experience, you'll get the confidence, because we have now completely shifted to the SUBA preparation.
That's great, sir. That was a learning point. And there is a question about methylprednisolone. How good, bad in comparison to the standard we have discussed?
Which one? Sorry,
Methylprednisolone.
methylprednisolone. I don't use at all. First, it's expensive, and compared to prednisolone, in fact, has no advantage over prednisolone. And further, if you're trying to use itraconazole, in some patients it can cause side effects. So I don't use methylprednisolone at all. If you're using methylprednisolone, you are welcome to use. I mean, there is no harm in using methylprednisolone, but please at least don't combine with itraconazole. That is the crux here. So if you're using a combination therapy, don't use methylprednisolone.
Sir, in treatment dependent ABPA, is
In treatment
methylprednisolone
dependent,
better? In
sorry,
steroid resistant ABPA, does
yeah,
methylprednisolone fare better?
no. Methylprednisolone has advantage only in one specific situation, in patients who are on high dose oral steroids and still the ABPA activity is not controlled. So these patients have glucocorticoid receptor resistance. So only in these patients, high doses of methylprednisolone, say 10 to 15 milligrams per kg bolus, can bypass the glucocorticoid resistance, because it acts through the genomic effect rather than through the receptor, and can bring about its effect. So only in those patients methylprednisolone pulses are required. But in routine, I don't see any data or any personal experience of seeing any advantage of methylprednisolone over conventional prednisolone.
Yes, sir. Thank you, sir. And some points more about treatment dependent ABPA, in
Yeah,
which maybe like you have written in the guideline that continuous low dose glucose steroid should be the last option in managing treatment
correct,
dependent ABPA. So if
correct,
you can deliberate
correct.
more
So
on that, it would be helpful.
So there are three treatment or three evidence-based options for treating treatment-dependent ABPA. First is long-term itraconazole. So the data comes from two pivotal trials conducted almost 2.5 decades ago. One published in the New England Journal of Medicine, the other in the Journal of Allergy and Clinical Immunology. Both showed that if you use itraconazole in steroid-dependent ABPA, it can decrease steroid requirement and so on and so forth. So we have extrapolated that evidence for treatment-dependent ABPA. So how do you treat this treatment-dependent ABPA? So let's say a patient comes to you with recurrent exacerbations. So there you first control the acute episode by giving either prednisolone and itraconazole, and then you continue this patient on long-term itraconazole alone. So this is how so this is
So how
the
long?
same for all the three agents. So first control the acute episode with prednisolone and or itraconazole, and then you can use either long-term itraconazole, nebulized amphotericin B, or a biological agent. So if you see the strength of consensus, it was almost 100% for itraconazole and nebulized amphotericin B, whereas it was about 80% odd for biological agents. So there also everybody felt that more data is required. So hopefully the dupilumab phase 3 trial will give more confidence. Please remember that ABPA is different when compared to severe asthma, because in ABPA the fungus is actively growing inside the lungs. So you have continuous antigen presentation to the immune system. So it is very likely that biologic may actually fail if you don't use antifungal therapy.
That's a great point, sir.
Yeah.
Thank you for that. And sir, as you told that omalizumab you have used in many patients, and
Yes.
if you can share a bit details about
Yeah, so what we do is first we exhaust all the routine options, prednisolone, itraconazole combination, and so on and so forth. And only if the patient is still treatment dependent or is having a recurrent exacerbation, like the patient I showed, only then we use omalizumab. How we calculate the doses? 0.016 into patient's body weight into total Ig. So that is the milligrams of omalizumab, which we round off to the next 150 milligrams. Next, we round off to the next 150 milligrams, and then we use. So if the dose comes to say 150 milligrams, then we will just use every 4 weeks. But if it comes to say 300 milligrams, then we'll use 150 milligram every 2 weeks, and so on and so forth. The maximum dose, but we don't exceed, is 750 milligrams because it becomes prohibitively expensive. As it is, even 750 milligrams is about 40,000 rupees. With discounts, etc., will come to 32,000 rupees per month. And this has to be given indefinitely. It's a fairly
Any other,
expensive treatment option.
so any other biologics your unit has been using, which would
Yeah,
be?
we routinely use mepolizumab and benralizumab in adult patients with ABPA who are treatment dependent or who have recurrent exacerbations. And I mean, that's what I believe. The experience is mixed. Some patients really respond well, but some patients do not respond. So, and in these patients, you have to give itraconazole, and then that's why I'm waiting for the RCT data to mature. Only then we can have some confidence, because in our small experience, we are not very sure whether it is working or not working. But yeah, we have used mepolizumab and benralizumab both. Between the two, I prefer benralizumab because it causes complete eosinophil depletion. Plus, the dosing schedule is every 8 weeks.
Okay, sir. So there are many children who are like steroid dependent, and we end up giving them steroid continuously. So when do we switch to biologics, or when do we put them in between, or how do we
So
initiate?
I would, for me now, with the current guidelines, I see no reason why a patient or a kid should be on continuous steroids. The kid should be on continuous itraconazole. I mean, and the patient or the kid has no response to itraconazole or does not tolerate itraconazole, only then we should switch to some other option. Plus, I think if the patient is requiring repeated treatment courses, then the kid is really a candidate for biological therapy. So I think we should move to the in my experience, the rate limiting step is the cost of the therapy. If the patient can afford therapy, then I think we should quickly move to biological agent. There's no point waiting for that. There's no point giving long-term steroids, causing stunting of growth and etc., and then repenting later that we could have used a biologic. I would really use it quite upfront in pediatric UVA. I mean, the treatment approach should be very aggressive in pediatric ABPA because you are seeing you're seeing a kid in the foundational, transformative, and growing phase of his or her life. So I think it's very important that we take a very aggressive approach.
Yes, sir. Thank you. That was prudent. Sir, and do you think this 4 months or 16 weeks course of itraconazole can be further brought down, or versus glucocorticoids, which you say that should be given for 3 to 5 months, can be further brought down, or is it?
Yeah, I think we are working on that.
Yeah,
We're, we are doing a factorial trial, brevity ABPA trial.
yeah,
So, so we'll see how it comes out. Here we are not looking at itraconazole dosing, we're looking at prednisolone dosing. So can we
right,
bring down the prednisolone dosing?
right,
So
sir.
one contention was, can we really bring down the prednisolone dosing so that, you know, even for those acute episodes, it's acceptable. So first approach was deflazacort. So the data is matured. Hopefully in the next 6 months, it should be under publication. The second is the duration of steroid. So I think that this factorial trial will help us.
So the guideline also talks about environmental control. So if you can just summarize and how good we can utilize it in our children.
Yeah, so for patients with ABP, we tell them that there should not be any moisture on the walls in house. Any visible fungus should be promptly removed. Uh, the, 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 the patient should not do any activity which exposes the patient to compost, heaps of leaves, etc., because handling that will, aerosolize Aspergillus conidia and can trigger an exacerbation. So these are the advice. Plus, I tell all my ABP patients to do wet mopping at home, not to do dry mopping. So no jhadu, that they start sweeping the floors and aerosolize all the choroidea. And if the patients can afford, I tell them to do vacuum rather than that chhada pocha of the house. No? So we don't advise that. So these are the environmental control. Plus now we need RCDs, whether an air purifier or an air filter at home will decrease the risk of exacerbation. So I think the Japanese group has started a RCT on environmental control in ABPA. So I think probably in another year or so we'll be able to understand how environmental control is useful for controlling the disease activity.
Thank
But
you,
other
sir.
than that, I think these small measures are very useful for the patients.
So there should be counsel. The parents should.
Yeah, there should be counsel. I have a patient information sheet where I write all that and give it to the patients. These are given
Great.
to all the patients as such.
So there is a question on research methodology also. If you can just, so how are the evidence-based guidelines following grade methodology different from Delphi method and consensus method?
Very, very, very important and very nice question, because you have a ABPA guideline from the pediatric group led by Professor Joseph Matthew, where they say that itraconazole has a low level of evidence because of weakness in the RCTs and so on. And then they say this. Now, for instance, let's say we used this methodology, then we'll not be able to give any recommendation. We'll say, yeah, itraconazole, there was an RCT which was weak. So what? So a clinician will ask, what will I treat the patient with? So that's why we adopted this Delphi methodology, because it not only ensured a robust methodology, but expert and genuine expert consensus. So we had 2 anonymous rounds, which allowed for refinement of concepts and other things, and 1 in-person round where we gave the final recommendation. For instance, had we been purists and performed a true Delphi methodology wherein all the rounds are anonymous, and let's say no consensus is achieved on reaching the ABPA diagnostic criteria. So what will we write in the guideline? We cannot propose any diagnostic criteria because the experts could not reach a consensus. So it's not possible. So for disorders where the evidence is few, lacking, or conflicting, there this Delphi methodology scores over the grade methodology. Where the evidence is profound, let's say you have 10 or 12 RCTs in each area, there the grade methodology will obviously score over the Delphi. So whatever the experts may feel, you have high quality RCT evidence that will overrule your whatever clinical judgment. But if the evidence is lacking, there the Delphi methodology really scores over the grade methodology.
Yeah,
I
thank you,
hope that
sir.
has answered the question, at least partially.
Yeah, and Dr. Rawat is here, so I
Mhm.
think he's happy. Sir, and
We can have more discussion later on the
yes,
email. I can, whoever is interested can write to me
yeah,
on the
sure,
email.
sure.
I'll
Meanwhile,
promptly answer all emails.
yeah, I would request Dr. Javed to check if there are any questions from the attendees or the delegates we have in the meeting, and if we
I
can
think you
accommodate.
have taken up all the questions.
Okay.
I think it was elaborate. There are no questions I can see.
Okay, sir. And then in the end, something for us as a future direction, if you can give, Dr. Ritesh, sir, for
I
the
think
pediatric group, for the pediatricians. Yes, sir.
I think most important thing is uh, wherever I travel across the globe, the most important thing they ask is why ABP is so common in India. And more astonishing is the comment that they are yet to see any ABP in children. For instance, in the US and the UK, they have not seen ABP in children other than cystic fibrosis. So they really wonder why this ABP is occurs so much in India. So I think the future, there are 2 important things apart from all these cutoffs and treatments. Is why is India so prone for ABP? And I think the answer lies in host susceptibility. So we need to study the genetic predisposition in both the adult and the pediatric populations and answer this burning question that why is it so common in our population? I mean, people from outside who come to our hospital and who visit our ABPA clinic, they are completely astonished. They say, I've never seen so many ABPA patients which you see in one day. They have not seen so many ABPA patients in decades. So, I mean, that is what their comment is. So, I think that is one important future direction, both for you as well as for me. And we must answer this important question. I think we will answer. Now, Valliyappan has gone to US and learned some experimental methods. And with the pediatric immunology, I think pediatric immunology is doing great work. So we can join together and really we can answer this important question.
Yes, sir. So anything else like in the clinical practice and also for research?
I think screening one important and not to use too many steroids. I think that for me, I feel very upset when I see a kid with steroid side effects. I feel it's a missed opportunity. We could have easily used itraconazole, prevented all those growth retardation and weight gain and other things. I mean, other than that, I think more research. I think that is for me everything rotates and revolves around research. So I think more ABPA research from the pediatric world would really make a great contribution to this disease. On the adult side, we are doing our best, but we really require more research from the pediatric.
Yeah, thank you so much, sir, for that informative session. Those very minute details that you have shared with us, which were
And
very enlightening. And
I would
I think
urge
from
the
my side,
participants,
yeah,
just one comment that I would
yes,
urge the participants, if they have any
please.
questions which they think are not answered, you can email. I really like people asking questions because that's the whole purpose of these presentations. You must answer, in fact, I always, if I'm the moderator, I say you wring the speaker dry. Don't leave him like that. He or she should be, completely, they should go back with the impression, oh, आज तो मुझे निचोड़
But
दिया पूरा.
sir, but I'm sure Dr. Rawat would agree कि मैंने भी आपको निचोड़ दिया.
So,
Sir, so from my side, all questions are over from the chat box. So over to you, Dr. Javed and Dr. Rawat, sir.
thank you very much, Ritesh. This has been a dream session, I would say, and we always wish that this thing to go on and go on because there are a lot of unanswered issues regarding pediatric EPP, but then all good things have come to an end. I think you have done an excellent job in clearing almost all the doubts, all the concepts regarding ABPA, and I think the audience must have benefited immensely. I'd like to thank Pankaj sir to take this moderation of this session very beautifully. He has tried to extract as much information from you as he could in this limited time. So thank you very much. I'd like to thank Dr. Javed Iqbal sir to be the coordinator for this session because without him taking initiative, this thing not even possible. So I'll thank Dr. Javed sir. And just a last word, as Dr. Ritesh, I told you, we in IPNRC, we have made an evidence-based guidance development group under the chairmanship of Dr. Joseph Matthew. And 3 years back, we had looked after this issue and we had looked seven PPQ questions where we had evidence-based guidelines following great methodology. It has been published in Indian Journal of Pediatrics in
I
2023.
have gone through that.
So that is the first attempt we have made. And let us hope that we'll refine this more and more and we'll come out with more and more effective guidelines. So, Ritesh sir, we'll be in touch with you for any help regarding work in ABPM. Surely, we'd like to have you on more and more on this platform and help you us in diagnosing, treating, and making guidelines on ABPM. So, thank you very much. We are highly obliged. Thank you very, very much.
Thank you, sir. Thank you.
But
The pleasure was all mine.
and we come to end of this session, and we again meet next month in the last Wednesday of November with a fresh webinar. Till that time, good night and goodbye from IPNRC. Thank you very much. Thank you.
Thank you so much. Thank you so much.
Thank you, Javed. Thank you.
Thank you, sir. Thank you so much.
Thank you.
Okay, bye.
Thank you, Pankaj.